For our next speaker, I would like to invite Dr. Prithviraj Bose. Dr. Bose completed his medical school from the University of Calcutta in India. He then completed his internal medicine residency from the Henry Ford Hospital in Detroit, Michigan, and a clinical hematology-oncology fellowship from the University of Oklahoma. He is currently an associate professor in the Department of Leukemia at the MD Anderson Cancer Center. He is leading a number of important therapeutic clinical trials in myelofibrosis at MD Anderson, as well as in other MPNs such as essential thrombocythemia and systemic mastocytosis. He will be talking about novel agents and combinations for myelofibrosis beyond Ruxolitnib. Dr. Bose?
Thank you, Jasleen. Thank you, Dr. Chang, and all our friends at Methodist. As you see, my topic today is beyond Ruxolitnib, so newer drugs, combinations that are being developed for myelofibrosis. My interest is primarily drug development, and of course within the MPN space, myelofibrosis is where most of the action is. So Ruxolitnib, of course, has been our cornerstone of therapy for myelofibrosis for 8 to 9 years now. This is a drug that produces dramatic and rapid benefits in terms of symptoms and spleen. For patients, it's truly been a game changer in the field, I believe, and has become the mainstay of therapy and has a survival benefit in patients with intermediate to and high risk disease that as was shown in the long-term follow-up of the COMFORT trials. But today's talk again is on newer agents and where we go, what might be next on the horizon, and some recent approvals as well in the field. All right, so this shows you the kind of the JAK inhibitor story, which is a little bit of a checkered path, as I'm sure many of you are aware. Some of the JAK inhibitors had to be discontinued because of toxicity. There were others like momelotinib and pacritinib, which were in phase 3 trials that did not gain them approval, regulatory approval, but which may have a second lease of life and are entering phase 3 trials again. With a different design, different population, to try and see if those drugs can be approved. Of course, Ruxolitnib has been around for a while, and since 2019, we have fedratinib, which is also an approved option. Fedratinib is a JAK2 inhibitor, whereas Rux, of course, as you know, is a JAK1, JAK2 inhibitor. Now, getting straight into fedratinib, as this, remember, is an approved option at this time. Let's go over the Jakarta study, the study that led to the approval of fedratinib. So this study is actually not a new study. It's important to sort of remember that. It was actually published in 2015, as you see at the bottom. And after that, the drug, as some of you are aware, was actually discontinued for a while by Sanofi, the original manufacturer, because of concerns over wernicke's encephalopathy. And now it is again back, and we will touch on that story. But this is just a reminder that this trial was sort of contemporary with the COMFORT trials, not quite, but soon after. So this trial was also a placebo-controlled study like COMFORT 1, and 2 doses of fedratinib were looked at, 400 and 500, as you see on the slide. Platelets had to be 50,000 or higher. Now remember, in COMFORT, they had to be 100,000 or higher. So that is one difference. And otherwise, the patient population, again, was the usual intermediate to and high risk by IPSS with splenomegaly. Now, moving on to the primary endpoint, as you are well aware, JAK inhibitor trials in myelofibrosis or MPNs in general often look at the 35% spleen volume reduction as their primary endpoint, and this one was no different. That was the primary endpoint. You see here that both doses of fedratinib were significantly superior to placebo. You had 36.5 at the 400 milligram dose. Now, just to put put things in perspective, in Comfort 1, this percentage was about 41 to 42. So very similar, 36.5 here. One important difference is that in Jakarta, they actually reported the results that were confirmed 4 weeks later. A little bit of a departure from the other studies. So you had to do the MRI one more time 4 weeks later to confirm the spleen volume reduction. And that might be the reason that the rate is a little bit lower. But 36.5 at the 400 milligram dose, you see the symptom score nicely going down on the right side of the slide. Now, side effects, Jakarta, in this trial, remember fedratinib is a FLT3 inhibitor. Unlike ruxolitinib or momelotinib, fedratinib is a FLT3 inhibitor, and like you know from midostaurin, which I'm sure you use for AML and sometimes mastocytosis, anytime you inhibit FLT3, you're going to get nausea, vomiting, and diarrhea. That's just an on-target effect. So it's important to prophylax against those things. And then anemia, thrombocytopenia, of course, anytime you inhibit JAK2, you're going to cause myelosuppression. Now, this was, of course, the Wernicke story, which sort of derailed the drug for a few years. Remember, like I said, it belonged to Sanofi initially. Obviously, Jakarta was a positive trial, but then there were these cases of presumed Wernicke's encephalopathy. So one case definitely was confirmed, and this led to the company, frankly, shelving the drug, and years later it was picked back up by Impact Biomedicines and then bought over by Celgene, which is now BMS. So the fedratinib label has a black box warning, though, even though this is an extremely rare complication. It is there, it's important. It is important to check thiamine levels and not give fedratinib if they're low. It's important to replete the levels, and you should be concerned in a patient that's alcoholic or is malnourished for thiamine deficiency, which can precipitate this very serious complication. Again, very low rates, one confirmed case, a couple of presumed cases, possible cases, I should say, with some confounders, and then several other cases which were not felt to be Wernicke's upon reanalysis. So moving on from there to Jakarta 2. So this is important, and Dr. Teferi alluded to it this morning that fedratinib is an option after ruxolitinib failure, right? So this was the study done in that setting. Now, important to understand here again, first of all, it's an open label study. It's a single arm, open label. It is not a comparative study. Secondly, and even more important, is that there was no uniform definition of ruxolitinib failure. It was at the discretion of the treating physician. As long as the patient had had at least 2 weeks of ruxolitinib, they could qualify, as long as their physician felt that this was a patient that was intolerant of Rux or resistant to Rux. So that was how the study was originally designed. Again, we're talking about these in 2020, but these studies were started much earlier. As you see, this paper was already published in 2017. So fedratinib dose was 400 because that's the dose that emerged from Jakarta. It is the less toxic and equally effective dose. So really that's the dose that has gone forward, platelets 50 and higher. So this was the original results. These were the original results of the Jakarta 2 that were published in 2017. Now, what really took people by surprise in the field was this 55% spleen response rate. So which is kind of remarkably high in a second-line setting after ruxolitinib. So, and you will see that this, frankly, none of the others have even gotten close to that number, 55%. But the question is why? So remember, I mentioned that this was a study where patients were enrolled essentially per physician discretion without a rigorous definition. And secondly, because of the Wernicke issue and the drug essentially getting discontinued, a full clinical hold being placed on the trials, the patients had to come off. And because they had to come off, the 12-week spleen measurements were extrapolated over to 24 weeks, something that is called last observation carried forward. So many of them didn't actually have the 24-week MRIs. So these were some issues with the study, which led to a reanalysis first presented at ASCO in 2019 and published in 2020 in the American Journal of Hematology. And that's what you're looking at here. Now, I don't have the stringent definition that they employed on the slide here, but essentially they tried to define Rux resistance or Rux intolerance. And that was essentially how long you had to be on Rux, how much your spleen had to increase, or lack of reduction, if you will. And then for intolerance, again, defining how long you had to be on it and documenting grade 3 hematologic toxicities. So you had to be on Rux for at least 6 months for the resistance, and you had to be on it for at least 4 weeks for the intolerance. So those criteria are well outlined in the paper and in the presentation, but here are the results. So the takeaway from this is that the spleen response rate is 30% and the symptom response rate is 27%. So still decent, but a lot more practical or a lot more believable than the 55 that we just talked about. So 30% spleen, 27% symptoms. And strikingly, note how when you looked at the entire trial but did the intention to treat analysis, you frankly came to the same identical results for spleen and symptoms, 31 and 27. So let me just clarify that again. What I showed you on the previous slide was per protocol analysis. But if you did intention to treat, you got 31 and 27, which is the same as what you got when you only looked at the patients that met the stringent criteria for Rux resistance or intolerance. Moving on to momelotinib. So momelotinib, again, Dr. Teferi alluded to this morning, is a drug that can improve anemia. So how do you improve anemia if you block JAK1 and JAK2, particularly JAK2? Well, you do it, at least for this drug, through blocking the ACVR1 or the activin receptor type 1, also known as ALK2, and basically suppressing hepcidin. So the liver produces hepcidin. As you know, hepcidin drives anemia of chronic disease. So momelotinib through the ACVR1 pathway suppresses hepcidin. Now, key trials, this drug has also been in 2 phase 3 trials, Simplify 1 and 2. Just to orient you, Simplify 1 is on the lower panel on the table here. Simplify 1 was a head-to-head versus Rux. And it did not really get the drug approved. Why? Because it was, again, like I said, a non-inferiority head-to-head trial where it was non-inferior to Rux for spleen, but not for symptoms. And the exact numbers are shown on the slide. Well, then Simplify 2 was done. This was in a post-Rux population, so second-line trial after Rux. Now, the problem for momelotinib in this trial was that the best available therapy, which was the comparator arm, ended up being Rux in like 88% of patients. So it almost became another momelotinib versus Rux trial, only in post-Rux patients. So here, the spleen was the primary endpoint, and it was not met. However, there was a signal for symptoms, and that's interesting because of what I'll show you on the next slide. In Simplify 2, the symptom improvement with momelotinib was an interesting 26%, whereas the best available therapy, which remember was mostly Rux, was only 6%. So this is the upcoming study. This is the study that hopefully we can all enroll to and is going to lead to approval for this drug. It's important, of course, to get a JAK inhibitor that improves anemia. So definitely an unmet need. This is the trial design, 180 patients. These will be prior Rux, or prior, JAK inhibitor patients. So it's a second-line study. Now look at the primary endpoint. It's symptoms. It's not spleen. Symptoms, the primary endpoint, and anemia improvement, spleen improvement, those are your key secondary endpoints. What's the comparator? Danazol. Danazol is a reasonable drug for anemia. I'm not so sure about spleen and symptoms, but that has been chosen as the comparator in this study. It's a 2-to-1 randomization. Now the other drug is pacritinib, the other JAK2 inhibitor. Now this is just JAK2, like fedratinib, no JAK1. So pacritinib, the advantage of it is that it is relatively non-myelosuppressive. Again, why is not entirely clear, but it's non-myelosuppressive, relatively speaking, and this has been in several trials, as you see on the slide. Now, PERSIST-1, I'm not going to elaborate too much. This was a kind of a straightforward JAK inhibitor naive population. It was pacritinib versus best available therapy and pacritinib 1. Which is not surprising. This is JAK inhibitor naive population, and the comparison was not to a JAK inhibitor. Now note, however, that the spleen response rate was only 19%. Now we just talked about COMFORT-1, Jakarta, where it was more about 40%. So why might that be? Well, I mean, of course, these are different drugs and different trials, but also important to remember that in PERSIST-1, because this is a non-myelosuppressive drug, there was no lower limit for platelet count. So any platelet count was permissible. We know that's a more difficult population and they may have lower response rates. So that's just something to keep in mind. Now, PERSIST-2 was the more what I would call relevant trial, where patients could have had prior Rux, and about 45% had received prior Rux, and best available therapy could be Rux. So this was I think, a more robustly designed trial, the PERSIST-2, where they looked at 2 doses of pacritinib versus best available therapy, which, like I told you, could be Rux, and was in about 45% of patients. So prior Rux allowed, best available therapy could be Rux as well. And these were thrombocytopenic patients, platelets less than 100. So a little bit of a more difficult population, if you will, than the COMFORT trials. Now here, again, the drug could not get approved because it was superior for spleen, but not for symptoms, when you compared the pooled pacritinib data to the best available therapy. And these were co-primary endpoints. So you got one, but missed the other. Now, if you looked at only the 200 milligram BID dosing of pacritinib, now that one was superior to best available therapy, but that was not how the trial was powered, and it did not get approved. To make matters worse for this drug, at that time, there was significant concern mounting about cardiovascular events, bleeding, etc. And a full clinical hold was placed on these trials. After that hold was lifted, the company proceeded under the direction of the FDA with a study called PAC-203, which is at the bottom of the slide. Now, this was purely a dose-finding study. They looked at 3 different doses, trying to figure out the safest dose, and also building in a bunch of risk mitigation measures, like no anticoagulants, QT, being very careful about QT prolonging drugs, etc. And this found that 200 BID was the most effective dose. They did not see those cardiovascular or bleeding events. However, if you look at the bottom right, the response rates were sort of disappointing. 9% spleen response, 7.5% symptom response. But then again, difficult population. Many of them had low platelet counts, and really it was a dose-finding trial. Important to note that the response rate for the spleen was a little bit higher, actually 17, so about double of 9 in the patients with less than 50,000 platelets. So which brings us to the way forward for this drug. So this drug will be exclusively developed in patients with less than 50,000 platelets. Remember, there was a signal in this population from PAC-203, like I just said, and this is a non-myelosuppressive drug. As you are aware, neither ruxolitinib nor fedratinib have data in the less than 50,000 population. So we have an unmet need there. These are the eligibility criteria for this Pacifica trial. This is now open, including at MD Anderson. The momelotinib study that I mentioned will also open soon. Serge Verstovsek from our group is leading that. So back to the Pacifica trial, as you see, this is platelets less than 50, and prior Rux is allowed, but not more than 3 months. So not more than 3 months of prior JAK inhibitor, or 6 months if the dose has been no more than 10 a day. So either low dose Rux for 6 months or any dose for 3 months, but they don't want people that are extensively pre-treated. And the physician's choice is the comparator, which is essentially things like steroids, danazol, erythroid stimulating agents, not IMiDs. Those are the physician's choice options. Now, moving on from there, we covered the JAK inhibitors, and I won't go through this slide, but this is just to show you that because of the success of Rux, there are many drugs that are attempting to build around Rux, build on Rux, and develop a combination that can either help the cytopenias, which are a problem with Rux, as we've discussed this morning, or synergize with it and give us deeper responses. You know, Rux is primarily a drug that is good for spleen and symptoms, so we would like something that is more disease biology focused. So these drugs are of interest because luspatercept, as you know, is FDA approved. It's approved for MDS and beta thalassemia. So what are these? They are activin receptor ligand traps. So these are your fusion proteins. They are fusion proteins that essentially sequester these ligands of the TGF-beta superfamily, not TGF-beta, but that superfamily. They bind those ligands and block their interaction with the activin receptor. By doing so, they improve anemia because these ligands suppress hematopoiesis. Now, this is the study design in myelofibrosis. Remember, it's not approved today in MF, it's approved in MDS. But this is the study design. This is from ASH 2019. It looks a little complicated, but if you focus on the left upper part of the slide, there are really 4 cohorts. They can be either people who are not needing any transfusions, or they can be formally transfusion dependent. And then those are broken down by, are they on Rux or are they not on Rux? So that's your study design essentially. Here are the results. Now the dark blue is the primary endpoint. The lighter blue is your secondary endpoint. So the primary endpoint for transfusion dependent patients is obviously transfusion independence. And for patients who are not transfusion dependent, for them, it's a sustained increase in hemoglobin by 1.5. You have to sustain that for 12 weeks. You've got to sustain anything for 12 weeks, essentially by the IWG criteria. So as you see, if you look at the dark blue bars, generally you get the feeling that the patients on Rux are doing better. Now, this initially seemed counterintuitive because, you know, not only do they have MF, they also are on Rux, which is going to suppress their hemoglobin. So why are they doing better? That's not entirely clear. But that seems to be the signal, and the company is taking this forward in that population, patients receiving Rux. In fact, this particular study has been expanded for the transfusion-dependent cohort on Rux. And again, quickly, as to what the light blue bars are, those are your secondary endpoints, which is a 50% reduction in transfusions or a mean increase of 1.5 in hemoglobin. Not an increase at every time point, but just a mean increase. All right, so moving on from there, there's lots of drugs, as Dr. Teferi mentioned this morning, representing various classes that are being investigated. I'm just going to show you 3 of them. There's many that are being explored. So this is the bromodomain inhibitor from Constellation Pharmaceuticals. Now, there is some really nice synergy between Rux or JAK inhibition and bromodomain inhibition. It's dependent on NF-kappa B primarily because bromodomain inhibitors interfere with transcription. So ultimately you shut down the cytokines, etc. So this is the study design. It's a big study. It's a big study, kind of think of it as almost 3 studies in one. So you've got the arm 1, which is receiving the bromodomain inhibitor as monotherapy. And then you've got arm 2, which is getting it as an add-on to patients who are on a stable dose of Rux, but are having sort of a suboptimal or insufficient response. And then arm 3, which was added later, is frontline. Frontline JAK inhibition with BET inhibition. So that's kind of the latest arm. So this is the study design. It's about a 100 patient study. It's a fairly large study compared to some of the others that we have now. Now, and it's a pretty logical, intuitive endpoint. If they are transfusion dependent, the endpoint is transfusion independence. If they are not transfusion dependent, the endpoint is 35% or higher spleen volume reduction. So with that background, this is showing you arm 1 and arm 2, which remember again, arm 1 is monotherapy, arm 2 is with Rux. None of this is frontline. They're all patients who've either had Rux before or they are on Rux but not having a very good response. So the color coding is there. This is your spleen response slide. You see there's more orange than anything else. And this is the group, the cohort 2A, which are the folks on Rux and transfusion dependent who appear to do the best. And same thing now for the symptoms. Here again, it's that cohort, the orange, where the drug is added, BET inhibitor is added to Rux in transfusion dependent patients. But here also cohort 1B in the dark red, which is the monotherapy in non-transfusion dependent, seem to do quite well as well. Now, one last thing before we get into the front line here. With this drug, remember, anemia is a major unmet need in MF. It's a luspatercept, might be an answer, but probably will not be the answer. And this is a difficult problem. We need multiple drugs. So CPI-610, the bromodomain inhibitor monotherapy, also actually shows a signal for anemia. This is the cohort 1 patients. 1B means not transfusion dependent monotherapy patients, where you see an increase in the hemoglobin. Now, here is where the excitement currently is, because this drug is going into a frontline pivotal trial of CPI-610 with Rux versus Rux alone. Now, that is not what I'm showing you on the slide, just to be clear. That is being designed, developed, that's coming. But this is the frontline cohort of the study I'm showing you, the MANIFEST study, where you see this 63% spleen response rate at 24 weeks. Which is better than what we saw with Rux alone. Again, different trials, but there could be some synergy here that we are starting to see. And here is symptoms. Again, about a 59% response rate at 24 weeks. Again, higher than what you expect from Rux alone in the pivotal COMFORT trials, where it was more like 45%. So 42 spleen, 45 symptoms. This seems to be higher. Caveat is that the Rux dose was 1 dose level lower because of the combination of the two drugs. The Rux was dosed at 1 dose level lower than you would think appropriate for the platelet count. Now, like I said, I'm going to discuss just 3 drugs in all among these newer ones. Navitoclax is the other one. You're all familiar with venetoclax. Now, Navitoclax is actually an older cousin of venetoclax, which blocks both BCL2 and BCL-XL. BCL-XL believed to be more important in MPNs because it's a direct target of JAK2. So this is why this rather than venetoclax is being developed. Now, this is one of these add-on trials where you keep your Rux, you keep the stable dose, you add the navitoclax or add whatever drug you're adding to see if you can get some synergy and improve upon the suboptimal response. So here they had to have had Rux for at least 12 weeks, stable dose, and then you could add navitoclax if you still had an enlarged spleen. Now, these are the results for the spleen. This has attracted some attention. Now, just to put things in perspective, this is only 34 patients, just 34 patients, but you have this 30% rate of spleen response. And remember, whenever I say spleen response, I mean 35% spleen volume reduction. That's fairly standard. So 30%, which is actually a little bit better than anything else in the add-on setting. Symptoms, similar story, 35% here. And symptom response is your usual 50% decline in the total symptom score. 35% is what we see with this drug at 24 weeks. So, and this drug was also, by the way, navitoclax is also going into a pivotal trial with Rux versus Rux alone. And that's one of the thoughts in both frontline and in the suboptimal setting. So there's many others, which we clearly cannot cover. All of these are being studied as monotherapy. These are not being studied yet with Rux, or maybe 1 or 2 have been, but for the most part, these drugs are being studied alone. Of course, some are not, like I already covered CPI-610 and then PRM-151. The antifibrotic agent has also been studied with Rux, and then there's interest in PD-1, just like in every other field of oncology as well. But this is a kind of a listing of the various single agents that are being studied. Now, I'll show you just one of them. This is imetelstat. Imetelstat was, Dr. Teferi 5 years ago, we all remember the New England Journal paper with the pilot study that he did, which showed the early activity of this drug. This drug was then taken into an industry-sponsored randomized trial. There are 2 doses, as you see here. But what is really important is to look really quick at the definition of Rux failure. So it's very important as we compare across trials to know who the patients are. So the Rux failure here is defined a little bit differently from what we talked about for fedratinib, for example. But it's a reasonable definition. They have to have pain, spleen volume increase, or worsening splenomegaly, as is listed at the bottom of the slide. Now, there's a lot of numbers here, and we are getting close to the end here, but just to draw your attention to the top 3. Survival, I'll talk a little bit more about that on my last slide, which is coming up, but survival was striking here. So 28 months on the higher dose arm, and generally in the post-Rux setting, multiple groups, ours, Moffitt, and the Italians, have reported only 13 to 14 months. So the survival was sort of striking, but remember, this is not a comparative study. This is imetelstat, just 2 doses. Now, the lower dose was closed because of lack of efficacy. So we won't really get into that, but the survival was better than what you'd expect in the higher dose. Spleen and symptoms, not that impressive, but they're listed on the slide for you. So last slide here, just to show you again that it was the survival that really caught people's attention with the higher dose of this drug. And we will see where this goes next. There are clearly plans to develop it further. The blue here is the higher dose, the red is the lower dose, but that's holding up so far. This is from EHA 2020, so just 2 months ago, you have about this 28-month median survival. And that is everything. Thank you so much for your attention, and I'm happy to take any questions.
So I think we have one question that came in. They're asking, what are your thoughts on incorporating peginterferon after ruxolitinib failure? How would you choose which to pick first, JAK inhibitor or interferon?
Yes, thanks for that question. So interferon in MF, has not been as impressive or nearly as impressive as it has been in PV and ET. Remember, MF is a much more molecularly complex disease and frankly a more advanced form of MPN than PV or ET. So I don't expect interferon to work in Rux failure, in true Rux failure patients. I would not use it in that setting. The data with interferon in MF is really in very early patients. Dick Silver has published on that. And now there is a trial that Dr. Kilajian is leading in France. There's actually 2 trials, there's one other as well, where it's being combined with Rux. So I don't think interferon is for later disease. If I use it, I would use it in really early disease.
Thank you. I think that's all for the questions. Thank you, Dr. Bose.